So moving on to the specific objectives, these are the objectives given in your module book, which I have just copied and pasted. But we'll move on to the intermediate objectives for this lecture. So let's see what are the intermediate objectives. At the end of this lecture series actually on cystodes, you should be able to list the parasitic infections, that's cestode infections, cestode worms causing gastrointestinal tract diseases in humans. And also you should know their morphology, the life cycle, and how they are being transmitted to humans. And also you need to know the clinical aspect, the clinical manifestations caused by those parasitic infections, as well as the pathological impact by those parasites to the human body. In addition, later on you need to know how can you confirm those parasitic infections in the laboratory. Now you first get their history, a clinical examination, they will give you a clue to which parasitic infection this is, and then with the help of laboratory diagnosis, laboratory test, you are going to confirm the diagnosis. And in certain instances, there may be radiological investigations which can be done to diagnose certain parasitic infections. That also you need to know. Finally, you need to know the principles of management. That means, now here in the lecture, you are going to learn the principles of management, kind of the medical management or surgical, what kind of management aspects you are going to use to control or treat this patient. Now, the real management, of course, you will learn when you go for your clinicals. And finally, you need to know the prevention and control with little bit of epidemiology. Of course, epidemiology changes from time to time, but right now you are going to learn whether this disease is prevalent in Sri Lanka and what is the impact that it has caused for Sri Lankan community, and then how do you prevent and control this disease. Now, before I move on to the next slide, I would like to say that list is, when you are asked to list something, just name them. No need to go into further details. But if you are asked to describe, you need to go into details. You need to know a little bit of more details, like you need to know deeper in the particular topic. The discuss is, on the other hand, is you are discussing the advantages, disadvantages and different aspects of the particular topic. So those are the three different things that we have used in the intermediate objectives. So you need to know those things separately. This is the lecture outline. First, we'll have a brief idea as to the classification of Taenia solium and Taenia saginata, and then we will move on to the topic per se, that is the two species of cestodes, and there I will tell you about the life cycle, the transmission, the morphological identification of them. Finally, at the end, we will go to the infections caused by the two species of parasites. That is Taeniasis and Cysticercosis. Taeniasis is by the adult stage of the parasite of both species, and Cysticercosis is by the larval stage of the Taenia solium. So this is the classification that you already know. We are actually looking at the Taenia solium and Taenia saginata, which are two species in the order Cyclophilidium in the class Cestode. So let's get started with Taenia solium. Now, Taenia solium parasite lives in has two stages in the life cycle, that is adult and the larvae. So the host that has the adult stage is called the definitive host, and man is an example, and basically the man is the only definitive host for Taenia solium cestode. The intermediate host, there is a variety of intermediate hosts. The important thing to note is that man has become an intermediate host for this parasite as well. So basically the humans can be the definitive host harboring the adult stage, and man also can be the intermediate host harboring the larval stage of the cestode. So the diseases caused by Taenia solium are Taeniasis and Cysticercosis. Taeniasis is the disease caused by the adult stage of the parasite, and Cysticercosis is the larval infection. So moving on to the Taenia saginata. Taenia saginata is commonly called beef tapeworm, and the other definitive host is the human again. Again, man is the only definitive host harboring the adult stage of the Taenia saginata, and the intermediate host is the cattle. And this particular cestode causes only the taeniasis, that is by the adult stage of the parasite, because we don't become the intermediate host, as you can see in the slide. So now let's look at a life cycle. Now this life cycle is common to Taenia solium and saginata. So basically it's not that the two have sharing the life cycle, but this life cycle image has been drawn so that it explains both the life cycle of saginata and solium to both species. So as you know, we are the definitive host, so which means we have the adult stage of the cestode in our intestine, small intestine. And when the worm, the cestode, is gravid, when it has eggs, either the whole gravid proglottids can come out along with the eggs, that is the proglottids containing eggs can come out in the feces, or the proglottid can get disintegrated inside the small intestine so that the eggs are released directly to the feces and they come out in the feces. Now these will remain in the environment. So when the intermediate hosts such as cattle and pigs and other intermediate hosts, when they are ingesting various vegetations and grassing, during grassing, they will ingest these eggs and gravid proglottids into their body. So once ingested, the eggs hatch and the oncosphere which is inside the egg get released, and these oncospheres has 6 hooklets. With the help of hooklets, they can sort of penetrate the intestinal wall and get into the circulation of the intermediate host, and via the circulation they get distributed to entire body. So once they are distributed to various tissues in the body, they go and deposit themselves in various locations. So basically they encyst in various locations in the intermediate host. So how we get the disease is when we eat up the cyst containing muscle of the cattle or the pig. Then when we eat them raw or uncooked, we can get the infection, because we acquire the cyst contained inside the muscle by ingesting the raw or uncooked meat. So this is what I have just said, so I'm not going to read the slide for you. And these cysticerci can survive for several years. So basically, once we ingest the cysticerci containing meat, they take about 2 months to become an adult, and another few months to sort of produce eggs and release them into the body, into the feces. Now this image shows you the larval form which is found in pig, in the muscles of the pig. Now it is called Cysticercus cellulose. This is the usual naked eye appearance of it, and this is the diagrammatic representation. There you can see it has an invaginated Scolex inside the cyst. So this is kind of a fluid-filled cyst which has an invaginated Scolex inside. Now what happens is, when we eat up the muscle with this cyst inside, this invaginated Scolex here evaginates while it is inside the human. And once it is evaginated, here also in this image you can see the evaginated Scolex. So then this Scolex has the attachment organs such as hooks and suckers. With that, they adhere, they fix themselves onto the small intestinal mucosa and starts growing into an adult stage. Moving on to adult morphology. Now let's learn something about the adult morphology of both species as in comparison with each other. first let's look at the Taenia solium. Now Taenia solium is in the pig and it is relatively smaller in size in compared to the Taenia saginata, because Taenia saginata is longer than the Taenia solium. And if you compare the number of proglottids, in Taenia solium it has about 1000, whereas in Taenia saginata it has about 1000 to 2000. And if you look at the number of eggs per proglottids in Taenia solium, it has about 50,000 eggs per proglottid, whereas it is double the amount in Taenia saginata. And so you can imagine the size of the worms are quite different in the two. And the other thing is you have to understand is that per proglottid having 50,000 eggs means in a worm which has thousands of proglottids, any person harboring the worm should have a large number of eggs in their feces. Moving on to the Scolex appearance, both species have 4 suckers. Of course, the suckers have little morphological differences from each other, but if we leave it aside, both have 4 suckers. And in addition, solium has rostellum and hooks. So with that particular, especially with these hooklets that are present in the Scolex, if you find Scolex in the fecal sample, you can differentiate which species that you are looking at in the patient. So moving on to the mature proglottids, the mature proglottids in both, they are square shaped and then they are more or less equal or more or less identical, so that it's difficult to recognize whether it is solium or saginata by looking at the mature proglottids. By looking at the Gravid proglottids, of course, you can separate them. We will get into that in the next slide. But the shape per se, the Gravid proglottids in both solium and saginata, they are longer than the width. So basically, lengthwise, it is more than the width, and it has egg-filled uterine uterus inside the proglottids. So now this slide shows you the Scolex differentiation of the two that we just discussed in the previous slide, and then the mature proglottids that it has the same square shape in both, and the Gravid proglottids, the differences are given as well. So in the solium you can see it has less lateral uterine branches. It has about 7 to 12 lateral uterine branches, whereas the saginata has about 15 to 30 lateral uterine branches. So if there are proglottids found in the feces, with the help of the number of uterine branches, we can see which species is present in the patient. So now let's move on to taeniasis, the disease caused by the advanced stage of the parasite. Now taeniasis it can be caused by both the species, that is Taenia saginata and Taenia solium. And you can remember that I told you that the humans are the only definitive host for these both species of cysts. So basically the taeniasis infection is the infection. Now these adults live in the small intestine, so the adult worms are causing the infection in the small intestine. How they adhere is that they are sort of hanging on to the, you can see here, the Scolex is attached to the small intestinal mucosa, and then the rest of the body is lying in the lumen of the small intestine. Generally, there are only 1 or 2 worms are present. Since the Taenia solium is smaller in size, it does not cause intestinal obstruction in general. Moving on to the clinical features of taeniasis, most of these patients, majority of them are of course asymptomatic, or they may have very mild symptoms. So basically they don't show any symptoms at all mostly. If at all, if they are showing symptoms, of course saginata infections can cause more symptoms than the solium, probably because it's larger in size. so it can cause more impact on the small intestinal tract. And when they get symptoms, those are more of non-specific ones, and all of them are more or less relevant to gastrointestinal symptoms like the epigastric discomfort, nausea, vomiting, and flatulence, and abdominal pain, loss of appetite, and all. So, moving on to the clinical features again. Now, sometimes the presenting complaint of the patient is that they have seen some whitish particles coming out of their anus, or they are seeing some whitish particles in their feces, which are actually moving, actively moving, because the proglottids, even when they are detached from the main strobila, they can move on its own. So sometimes it's moving as well. So patients come and say this. And let's move on to the laboratory diagnosis. Now, taeniasis is diagnosed by detecting eggs and proglottids in the fecal sample. I said the humans are the definitive host, so we have the adult stage in the intestine, small intestine. So the gravid proglottids and the eggs can come out in the feces. So if you take a fecal sample and examine, we should be able to identify the eggs and proglottids present in the fecal matter. And these eggs and proglottids generally are not released to the feces till about 2 to 3 months after the adult infection is settled in, and the frequency of passage may not be unique. I mean, it's not constant every time, so you need to take about 3 samples on different days to identify that the patient is having a Taenia infection. And in addition, I told you, if you get mature proglottids, you may not be able to say which species that is, but if you get gravid proglottids, based on the lateral uterine branches, we can say which is which. And also, I mean, it's unlikely that the Scolex come out of the feces, but if it does, then the Scolex also has differences. But as you know, Scolex is fixed onto the intestine, so unless you treat the patient or unless the worm dies, it doesn't come out of the feces. Now, this is treatment of taeniasis. The treatment is generally praziquantel, the drug called praziquantel, which is given orally, but the availability in Sri Lanka is a query. Most of the time this is not available. So the alternative drug, which is the niclosamide, is being used for treatment, but the ideal treatment would have been taeniasis, would have been praziquantel. So once the patient is given treatment, after treatment, the feces should be collected for 3 days to make sure that the worm is coming out. Especially, actually, we need to look for the Scolex, but it's hard because I told you, even though the worm can be seen, the Scolex is quite small. So finding it in the sample of feces is not so easy. But to make sure that your treatment is effective, for about 3 days, fecal smears, fecal samples are collected and examined under the microscope. And generally, after treatment, stool should be re-examined after about 1 to 3 months time to make sure that the infection has cleared off. Because if you saw the Scolex, it's fine. If you don't see the Scolex, then you are not sure whether only the rest of the body has come out, only the strobila has come out, but if the head and the neck is remaining inside, attached to the small intestine, then it can regrow and cause an infection again. So you have to make sure that the patient is cured of by taking another fecal sample 1 month, 3 months apart later on. Prevention and control, it's easy because we get this infection by eating undercooked or raw meat of cattle and pork, beef and pork. So if we cook meat to safe temperatures before eating, then that's the best prevention and control, or basically the sole method of controlling the infection. So now we are moving on to cysticercosis. Moving on to cysticercosis. Now, cysticercosis is the infection caused by the larval stage of Taenia solium. Now, earlier when I was talking about Taeniasis, I told you it could be caused by both species of Taenia, that is solium and Cestode, but cysticercosis is only caused by the larval form of Taenia solium. Now, this larval form of Taenia solium is called Cysticercus cellulose. I may have used that term on images, so that refers to the larval form of the Taenia solium. Now, how do we acquire the larval form of the Taenia solium? Now, if you remember the life cycle, to acquire the larval form, you have to eat the egg. Now, egg has the larva inside, so when we ingest the egg, then only we will get the larval stage settling in our body in various tissues. So there are some people at more risk, like those, if there is anyone else at home who has taeniasis right now, that person has more risk because the taeniasis patient is excreting eggs in their feces, and so there can be contamination at home. And one thing you have to remember is you should not get mixed up with taeniasis. Cysticercosis is not acquired by eating undercooked pork, because when you eat the undercooked pork, which has the cyst has the larvae, and that larvae of course grow into an adult inside the human body and cause taeniasis. It does not cause cysticercosis. Okay, to get cysticercosis in our body, the larval cyst has to be formed. For that you need to ingest the egg. So this is the life cycle which you saw earlier. This is I have taken only this Taenia solium life cycle for this because Taenia saginata does not transmit, does not cause cysticercosis. Here, if we concentrate only about the man becoming an intermediate host, so that there are now humans are, when we are the definitive host, when we have the adult worm of Taenia solium, we pass proglottids containing eggs into the feces, expire the feces to the environment, or we release, we pass feces containing taenid eggs to the environment. Now these will remain in the environment. If we somehow ingest these eggs via contaminated food or water, or eating salads, unwashed salads and so on and so forth, or via touching hands, or it could be via flies, or somewhere, somehow through some mode, if we ingest these eggs, then it will get into our intestine, and the egg will hatch and release the oncosphere, which will penetrate the intestinal wall and get into the circulation. And in the circulation, they will spread all over the body, and they will go to all various tissues, and they will start encysting in those tissues. So basically here we are acting like the intermediate host. It's the same thing that happens in the intermediate host, but the only thing is we are an accidental intermediate host. We are not the regular intermediate host like the pig. So this picture here, of course, if you can see, this is the real appearance of Cysticercus larval form, but of course this is not from humans. This is from a pig. And this other diagram shows the diagrammatic representation of the cysticercosis. In another slide, we will see more details of it. So these things I have already told you, so I'm going to skip those. And this is the process that happens that I just explained. So now let's see the pathology and post-response to this infection. Now generally the number of cysts vary from 1 to 1000, and when there are small number of cysts in the tissues, there is not much of post reaction. But see now, we ingest the egg and they start growing to the full size of the, they start insisting when they are initially growing. This developing cysticerci acts like a slow growing mass, so it can cause pressure atrophy in tissues wherever they are located. And when we talk about the live cyst, of course, live cysts generally cause very less or no inflammatory reactions usually, so they are kind of, they stay in the tissues but does not cause much problem to the host. But if the cyst starts degenerating, then the problem starts, because degenerating cyst will release various antigens and provoke the post-inflammatory response that will cause problems to the kidneys. And after some time, certain cysts may get calcified, and those calcified cysts also can time to time release various antigens, so that also can provoke some amount of a post-immune reaction. And if there are necrotic larvae, of course, when it is necrosed, either they are partially absorbed or totally absorbed. Then if it is completely absorbed, there is not much of a problem. If they are partially absorbed, they can cause kind of certain focal scarring, especially if it is in the brain, that will cause problems to the host. So basically, the cysticercosis infection, the symptoms vary depending on the location, whether they are in the skin or cutaneous tissue, heart, or in the brain. Based on the location, the symptoms may differ. And also the size, obviously, because the slow growing or the tumor-like slow-growing tumor-like impact can only be relative to the size, and then the number, and of course, as I described earlier, the stage, whether they are viable ones, the live ones, or degenerating ones, or calcifying ones, or growing ones. So the symptoms depend on the post-inflammatory response to these ones. So typically the size of these cysts may vary from half a centimeter to 1.5 centimeters, or even it can reach up to the size of 5 centimeter. And generally the skeletal muscles are the commonest site to locate these. I mean, see these cysticercosis infection. And central nervous system infection is called neurocysticercosis, and that is of course very important because it can cause seizures, especially late onset epilepsy. One of the reasons, one of the etiological reasons is neurocysticercosis. Okay. And then it can also be found in eyes, skin, or heart. Now, when it comes to the CNS system, the neurocysticercosis, it could be either in the parenchyma or it could be located in the extraparenchymal. So the clinical features, as I said, differs based on the based on the number, size, and the stage. So even in the brain, it is the same. Now, generally, it causes if it is small or small number, it may not cause any symptoms. But if it is causing problems, it will be manifested as seizures, headache, confusion, those kind of non-specific CNS clinical manifestations. But based on the location, the patient may have either the difficulty with balance or maybe some other cranial nerve with abnormalities. It depends on the site, of course, as you can understand. So now this is a list of clinical manifestations that can be seen in a neurocysticercosis patient, but not all of these can happen in one patient. The different combination can happen based on the location, size, and the stage of the cyst. This is a picture showing the cyst in the muscles. Generally, they just apart from the disfiguration and the cosmetic effect, there is not much of a problem to the human. And now we will move on to the diagnosis of cysticercosis. Now, generally the cysticercosis is diagnosed with serology, that is detection of antibody mostly. So the tests which are commonly used are the enzyme link immunoelectron transfer blot or ELISA test that you commonly know, the enzyme link immunoassay. The samples used are the blood, even the CSF can be used. Generally, the serology is combined with imaging techniques, radiological investigations like CT or MRI, and if there are tissues which are being removed at surgery, then by histology through microscopy of the stain smears, we can demonstrate larval cyst inside the tissue sections too. So this is such a human brain tissue section showing cysticercosis. In the first one, you can see the Scolex shown with an arrow, and this is the bladder wall showing here using the dots, and the same thing I have given you in increasing magnifications to see the appearance clearly. So the management of cysticercosis, the most important is managing the neurological complications, not managing the parasitic aspect. So if it is neurocysticercosis, then relevant symptoms should be managed accordingly. For example, if patient may need anticonvulsant therapy, or he may need corticosteroids if patient has edema. So basically, it is relevant to the symptoms or the clinical manifestations that they have. And anti-helminthic treatment, of course, if it is indicated, must be administered with caution. Now, I told you when the cyst disintegrate, it triggers the host immune reaction, so it can sort of make the thing worse. So we don't want to provoke the inflammatory response and exaggerate the symptoms that the patient is having. So if at all anti-helminthic treatment is being given, it has to be given along with the steroid. So if you have any questions, since you can't ask here, you may, when you meet me, you can ask the questions if you have any, or you may discuss these things at the tutorial classes that we